Welcome back to the Vicky tutorial video series. My name is Jennifer Brustrom with Biostat Global Consulting. In this video, I will provide a brief overview of how to read and understand the information that is presented in vaccination coverage and timeliness charts, also known as VCTCs. This tutorial is organized into three main parts. I'll describe what a VCTC is, how it's organized, and will explain key things to notice. After watching this video, you will be able to read and interpret the data presented in VCTCs. VCTCs are one type of figure produced by the Vaccination Coverage Quality Indicators, also known as VIQI. VCTCs summarize information about vaccination coverage and timeliness in a survey stratum, such as a nation, province, state, or district. The information in VCTCs may be particularly useful to vaccination program managers and evaluators who want to identify program strengths and challenges. The VCTC we'll use in this video summarizes actual state-level data from a recent demographic and health survey. All VCTCs have three main sections. The section on the left is a bar chart that summarizes information about vaccination coverage and timeliness. The section on the right includes 6 columns of statistics which describe vaccination coverage observed in the survey sample, the size of the sample, and some properties of the data. The bottom portion defines the color coding scheme used in the chart, as well as what is considered fully vaccinated and not vaccinated. Abbreviations for home-based record and several of the statistical concepts that appear in the graph are also noted. Starting with the y-axis of the VCTC, you'll see a list of vaccine doses on the National Vaccination Schedule, including BCG, the hepatitis B vaccine, the oral polio vaccine, and so forth. The vaccines in the list appear in vaccination schedule order, with earliest doses at the bottom and doses due at later ages progressively higher on the chart. The x-axis of the VCTC shows estimated coverage for each vaccine dose ranging from 0 to 100%. The data bar that corresponds to each vaccine dose provides information about the estimated coverage and timeliness of that dose. The length of each bar, which includes both the color-coded tiles and the gray tile, corresponds to estimated coverage for that vaccination dose. That is, the percentage of children in the study sample who received that particular dose. Using OPV1 as an example, we see that the bar extends to about the 85th percentile point on the x-axis. The color-coded tiles in each bar, situated to the left of the showed HBR line, provide information about vaccination timeliness based on dates from the child's home-based vaccination record. Continuing with the OPV1 example and referencing the color coding key, we only know the timing for about 35% of doses. Of those doses of OPV1 for which timing is known, about half are timely, with smaller percentages of doses being given too early, too late, or very late. The gray section of each bar represents the percentage of children who had evidence of vaccination but for whom the exact dates of the vaccination were not known. Looking again at OPV1, we see that among children for whom there was any evidence of vaccination, for about half of those children, the timing of that dose is uncertain. The graphic lines at the tip of each bar portray a two-sided 95% confidence interval. Longer lines are indicative of wider confidence intervals. In the case of OPV1, we see that the confidence interval is somewhat narrower than for the other doses. The rightmost section of a standard VCTC has 6 columns which provide statistical information about each dose. The coverage column tells what percentage of children received each dose. The confidence interval provides information about the precision of the coverage estimates, where narrower confidence intervals come from larger samples and focus our confidence around the region of the point estimate. Wider intervals come from small samples or heterogeneous samples and indicate greater uncertainty. N is the number of respondents whose data contributed to the sample size estimate for each dose. NEF is the abbreviation for effective sample size, which is a measure of how much information is contained in the survey sample compared to a simple random sample. DEF is the abbreviation for design effect, which is an adjustment used to calculate the effective sample size, accounting for the impact of the sampling method. ICC is the abbreviation for intra-cluster correlation coefficient, which is a measure of the relatedness of clustered data. Because this is an introductory video, I'll be focusing on just the leftmost 3 columns of the VCTC. Viewers interested in learning more about effective sample size, design effect, and ICC are encouraged to explore some of the additional resources which will be provided at the end of the video. Now that you understand how a VCTC is laid out, let's talk about 4 key pieces of information to notice in a VCTC. One of the first things you'll want to notice when you're reviewing a VCTC is the percentage of respondents who showed a home-based vaccination record. This detail is found just above the x-axis of the graph. In this example, 41.4% of survey respondents showed a home-based vaccination record to the interviewer at the time of the survey. Each VCTC includes a faint vertical line behind the bar chart to mark the percent of respondents who showed HBRs. A second type of information you'll want to notice is information about vaccination coverage. As discussed earlier, vaccination coverage refers to the percentage of children who received a particular vaccine dose. In a VCTC, coverage information for a given dose is shown in 2 ways: visually by the length of the bar corresponding to that dose, as well as numerically by the corresponding percentage in the column labeled coverage. When exploring vaccination coverage using a VCTC, you'll first want to look at the overall pattern of coverage. In this example, coverage spans from a low of 42% for Hep B0 to a high of 85.5% for OPV1, with many of the other values falling into the 40 to 50% range. Of course, ideally, all of the bars would extend all the way to 100% coverage. VCTCs also provide information about vaccination timeliness. As noted earlier, the color-coded sections of each bar to the left side of the showed HBR line indicate what we know about vaccination timeliness based on dates from the children's home-based vaccination records. In our previous example, we looked at timeliness for OPV1, which is due at 6 weeks of age, and noted that we only know the timing for about 35% of doses. Of those doses of OPV1 for which timing is known, about half are timely, with smaller percentages of doses being given too early, too late, or very late. In addition to providing information about timeliness for any single vaccine dose, VCTCs also relay information about the timeliness of doses within a dose series. Continuing with the example of OPV, we can compare timeliness of OPV1 with subsequent doses of OPV, including the dose due at 10 weeks of age, or OPV2, and the dose due at 14 weeks of age, noted as OPV3. As we compare data for these 3 doses of OPV, we notice that the percentage of children who received doses late increased for later doses in the series. The percentage of children vaccinated too early was highest for the first dose in the series, OPV1, lower for OPV2, and even lower for OPV3. We see similar decreases in the percentage of children vaccinated on time over these 3 administrations of OPV. VCTCs also illustrate dropout between doses. Dropout is the percentage of children who showed evidence of receiving the earlier dose by HBR or recall, but did not show evidence of receiving the later dose. The way we examine dropout is by looking at the relative lengths of the bars for early and later doses. Continuing with the example of OPV, we can compare the lengths of the bars for OPV1, OPV2, and OPV3. We notice that the bar for OPV3 is shorter than the bar for OPV2, which in turn is shorter than the bar for OPV1. This pattern is indicative of dropout in vaccination of OPV over time. If we want a precise measure of dropout, we can calculate it using this formula. Our calculation shows that between the dose of OPV given at 6 weeks, OPV1, to OPV3 given at 14 weeks, there was a 21.3% dropout. That is to say that the children who received OPV1 1 in 5 of them, 20%, dropped out and did not go on to receive OPV3. Generally, the World Health Organization describes dropout values higher than 10% as being too high. The VCTC can help to focus conversations among stakeholders on things that are going well as areas where there is room for improvement. Here we suggest 7 questions to discuss with the immunization program administrators and stakeholders when looking at a VCTC together. You should now have a basic idea of how VCTCs are structured, the information they provide, and how to interpret them. Links to additional information about the concepts discussed in this video, as well as other Wiki videos and resources, can be found in the video description below. If you enjoyed this video, please subscribe to our YouTube channel. Thank you for watching.